the smooth surface basal implants that are being trended, that are in the trend today, not just in India, but in Switzerland, Germany, and other countries as well. So I hope everybody has joined in. Am I audible to everyone? Please comment yes in the comment section, please.
Yes, sir, you are audible. Very good, audible. Thank you.
All right, sir. Thank you. So let's start with the seminar. The smooth revolution in cortico-basal implantology. So let's just start with the basics. I'm from the city Amritsar, Punjab, and I've done my BDS from Ludhiana, and I've been practicing since last decade now. And I have had experience practicing conventional implantology as well as cortico-basal implantology from past few years. And it's been almost 10 years that I have started placing implants as well. So basically, I'm going to, most of you must be familiar with the concept of implantology or the conventional implantology or the rough surface implants or the two-piece implants as we say in the clinical practice today. And I hope many of you have must heard about the basal implants, but you have never really got to know about what really basal implants are. So I'll be introducing you to the concept of cortico-basal implantology, immediate functional loading, and the smooth surface implants to be specific. So these are the basic three type of implants that we usually see in our clinical practice. The first, as we all know, is a conventional two-piece rough surface implant. We call it a two-piece because the fixture is a separate insertion in the bone, and then we put abutment over it to load it with a dental crown. So nowadays we have single piece compressive and smooth surface basal implants as well. You can see there is no attachment between the abutment and the implant. It is a monoblock concept. It is a single piece implant through and through connected via a neck or a shaft. And if you can observe the basal implant, the smooth surface implant, the third implant, you can see the screws or the threads of the implant are quite apical as compared to the other implants. So to understand the concept of basal implantology, we must need to know the concept of cancellous and cortical bone. As we all know, the anatomy of bone and the two parts of bone, that is cancellous and cortical bone. Cortical bone is basically present all over the body and it envelops the cancellous bone inside. The inner bone, the spongy bone, the cancellous bone is the bone which consists of soft spongy trabeculae, and our teeth and implants, the conventional rough surface implants, are embedded in this cancellous bone only. So we have been practicing this concept from last many years. We have learned this in our colleges through various courses, through webinars, and I have been also practicing the conventional implantology from a past decade now. So we have all been placing the implants in the cancellous bone. We have never really thought of the cortical bone. So the cortical bone is present all around the cancellous bone. So with the basal implants, we aim to reach the cortical bone. We aim to engage the implant in the deep, dense cortical basal bone. All right. So the bone has two parts, the alveolar part and the basal part, also known as the cortical part. The alveolar part is where the teeth and implants are usually placed. See, the teeth is in the alveolar bone. You might lose the alveolar bone with age, with atrophy, but you never lose the basal bone or the cortical bone, right? So this is a simple description of where the conventional and the basal implants are placed. you can see we are entering through the first cortex, the crestal cortex, that is also a crestal bone. As I told you, the cortical bone envelops the whole bone. It starts from the crestal part and goes to the apical part throughout. So we enter the first cortical and we end up in the rock hard second cortical with the basal implant, which is more dense, and we fixate the implant in the cortical bone instead of placing the implant in the less dense cancellous bone. It is usually porous, and that is why it takes more time to osseointegrate. So let me introduce you to the concept of osteofixation and osseoadaptation. You all can take screenshots of this page. It is very easy. It's a basic knowledge. So basically, osteofixation and osseoadaptation are two concepts on which basal implantology is based. We load the implants functionally within 72 hours because we can anchor the basal implant in the cortical or the basal bone to have enough primary stability. We get high torque when we engage the implant in the cortical bone. We usually get above 50 to 70 Newton centimeters of torque, and that is how we are able to load it functionally immediately. So when we fixate the implant in the basal bone, and we load it functionally, there is a micro motion that is happening at the bone implant interface, which results in formation of a dense peri-implant bone over a period of 6 months to 1 year. So the implant, when it is placed in the bone and the patient chews from that side, there is a micro motion happening at the interface of implant and the bone, where this micro motion is happening, and it results in the peri-implant bone, dense peri-implant bone formation. All right. So depending upon the osseointegration, fixation, and the osseoadaptation, we have three type of bone engagement implants. Conventionally, we have heard what we have been doing, what we are most practicing are the conventional two-piece implants. These are placed in the spongy cancellous bone, and these are mostly rough surface implants. And osseo, depending upon the osteofixation, there are basal implants. Basically, these are more traditional. These implants have been used in the orthopedic surgery, and this basal implantology concept is based on that orthopedic concept only. We fixate the implants in the cortical bone and load them immediately and ask the patient to move, or we immobilize the patient for a few days, and then we ask the patient to walk and do the routine things. So this is how, from where we got the concept of basal implantology for dental implants as well. So when we fixate in the cortical bone, it is actually called bicortical engagement, and it is preferably done with smooth surface implants. So there is another hybrid implants which might be partially smooth and partially rough, or rough throughout, and these are conical in shape. These are compressive implants, and we place them in the cancellous bone just like the conventional implants, but we get high torque as we depend upon the lateral corticalization of that bone while we place the implants. So when the atrophy of the jaws happen, it is in the mandible, the alveolar process resorbs and results in the resorbed atrophied mandible, which looks like the second picture, as you all can see. And same goes with the maxilla, the alveolar process resorbs, and we are still left with the basal bone, the cortical bone. The basal bone never disappears. When we see a edentulous patient, their alveolar process is resolved, not the cortical bone. The cortical bone always stays no matter what. And the cortical bone is the only reason that we can stand on our feet, and our bones can take the weight of our body. This is just because of the cortical bone that envelops the soft cancellous bone inside. So in maxilla, it is a bidirectional loss. The alveolar process resorbs from the crestal part towards the apical part, and at the same time, the sinus resorbs, it's pneumatized throughout life towards the crestal part. So hence we call it bidirectional loss. But again, still we are still left with the cortical basal bone in which we can engage the smooth surface implants. In mandible, loss of height and width of the alveolar process. Again, we are left with the cortical bone in which we can engage a smooth surface implants and load them immediately functionally.
टीवी मत देखना, सोना है तो सोना है, नहीं तो पढ़ ले.
This is my case that I have done with conventional implants few years back, and this is the pivot
टीवी
bone.
देखता तो 11 बजे तक टीवी देखता बेटा, तू तेरी सिटिंग बढ़ा, ठीक है?
The patient came for the
समझ रहा
restoration
बात को?
of the jaw. As you
15
all,
मिनट की सिटिंग नहीं है तेरी
there is
सिर्फ.
no alveolar process left to place the conventional implants. The sinus has pneumatized
कितने लाइंस होगी
till
टोटल?
the crest.
Please mute. Hello, sir. Can you please mute all?
Yes, sir. Yes. Am I audible now?
Yes, you are audible, sir. Please.
Yeah. Thank you. So I've done this case back in time about 7-8 years ago with the conventional implants and loaded them. The patient had a denture in the upper jaw, and at that time I tried to convince the patient to get the upper implants done as well, but the patient was saying that she had just the problem with the lower denture only, and she wants fixed teeth in the lower jaw only. So we gave them 5 conventional implants, loaded them according to the traditional protocol. And when the patient came after a few years for the restoration of upper jaw as well, we noticed that there is no bone left in the upper posterior region at all. The sinus has pneumatized throughout till the crest, and especially on the left side, as you all can see, there's a very less chance that you can even lift the sinus directly. It is very difficult to do these kind of sinus lifts. They usually fail because there is no alveolar bone remaining in which you can engage your implant even after you lift the sinus. In such cases, the basal implants come to rescue. You can do all on 4 as well, but seeing the opposite lower jaw, the lower jaw restoration with PFM and the implants, the opposing forces are going to be very high. And most probably you would have to give a hybrid acrylic or a hybrid PMMA denture over the upper jaw if you do all on 4, and that prosthetic will definitely fracture. That won't last long. So this is the main case where the pivot moment came in my life. This is the case after which I learned the basal implants, and I started doing the basal implants on my own, and I have not stopped ever since. So in this case, what you must be thinking of doing, the advanced procedures to gain height and width of the alveolar bone for implant placement in resolved cases. First of all, you'll think that we'll do sinus lift in this case, in this area. We might place a simple zygomatic over here and a pterygoid over here, and you can engage a few implants in this area, but still not enough length because this is the area of corticalization, and we usually place our conventional implants in the alveolar process. Here you might be able to do a little bit of a sinus lift and place implant, but do you really think that you'll be comfortable giving a prosthesis over these implants to this patient where the opposing forces are very high, the PFM and the osseointegrated 5 conventional implants? Then other procedures are alveolar ridge split, distraction osteogenesis, bone expansion techniques using osteotomes, platelet-rich plasma augmentation, and many more. Advanced bone grafting like synthetic bone substitutes, biocompatible membranes. There are a lot of things that we can't talk on about this. But let's say when you have started the conventional implantology in your clinic, there's a lot of investment that goes in. First of all, you buy a physio dispenser and you try to buy a good physio dispenser because you think that you want to get a good physio dispenser in the first go only, so that it might last for at least 8 to 10 years, right? Then you invest in a good surgical kit, you get associated with some implant company and you buy their surgical kits, you get good autoclaves, you don't want to mess up your case because of infection or if there is any problem in sterilization. You want to get at least minimal number of implants that are required at the point of surgery. You don't know what is going to be the width or the length initially. Even if you have got a CBCT done, you still have to keep at least 5 to 10 implants extra with you. And then you need RVG, OPG, and then if there is a complicated case, you pay the charges to a consultant as well, right? So this was the case after which the basals came into my life and my life got easy, my practice got good, money came in bulk and knowledge grew with time. So being a dentist, there's a lot of investments going on throughout the life. So we invest in courses, we invest in implants, we invest in equipments, we invest in scanners, we invest in advanced training and courses, and we also invest in prosthetic training because we don't want to put bad prostheses over good implants, and we can't afford that our implants are if our implants fail, then we have to do it for free sometimes, right? And now furthermore, not just this, we actually invest in advanced training and courses for these kind of cases that I have just shown you. You can't go ahead and place implants with a beginner knowledge, right? We invest in treatment modality kits like sinus lift kits. We get multiple implants like zygomatic implants, pterygoid implants. We get multiple prosthetic parts like titanium cylinders, multi-unit abutments. You learn about immediate loading. You learn about immediate temporary loading. You get a lot of kits. You get a lot of implants, and you do a lot of courses. And usually, it's not just one course that makes you learn everything. You go through and throughout your life. Even if you attend 4 or 5 courses, you still feel a void that there is some knowledge left to be gained. So fears, what are the major fears that come to your mind when you practice conventional implantology, especially for a beginner? Peri-implantitis is one and the most important complication in conventional implantology, especially in diabetics, hypertensive cases, and patients on blood thinners, smokers. Also, there is implant abutment junction micro movements that are happening all the time, which might lead to peri-implantitis. Poor oral health is what we see daily in our clinics. Patients do not come for maintenance follow-ups. Patients do not come up for follow-ups for your x-rays as well. You cannot see the patient's oral hygiene until they come up with a peri-implantitis or a mobile implant or a broken screw or a broken prosthetic. So this case that I have shown here, the patient lost his gingival screw, the gingival healing cap, and came to me after a year. The patient told me that he lost the screw a year. So what we do here, we remove these implants, we try to place implants again, and we put bone graft over it, uh, and then we expect the new implants to also integrate again, and then we load them, and it takes about 6 months at least when we do these kind of procedures, right? So the other nightmares are screw loosening. The abutment loosens after a few years. The screw can break. If someone has ever faced this situation in their clinic, the breakage of screw inside the implant, they must know how big a nightmare that is. It is a very nasty job to remove that screw and then expect the new abutment to fit in that same implant. It is very difficult. It takes a lot of effort to remove that screw. So there is also a chance of prosthetic breakage, mostly in Bruxer patients and in cantilever cases. In especially when we do all on four, we tilt the second implant to increase the AP spread, and then still there is a cantilever because you want to give at least 12 teeth to the patient. Then hell breaks open when there is an implant breakage. So this case came to me with the chief complaint of a sinus in this area. Patient had a cap over it, and I saw a long bridge from 3, 4, 5, 6, and 7 area. So I didn't know at that time that there is underlying broken implants in this case. So I took an X-ray and I saw that there is two broken implants as well. Also, if you could see, there is a broken screw inside the implant as well. Patient is a bruxer. Patient is on medication for various conditions, for heart condition, for diabetes. Is hypertensive. He has undergone CABG, and patient is good 70 years old, but still a good bruxer and has broken these implants. And patient has told me that previous dentist has placed these implants again after the breakage of first implants. So what we do in these kind of cases, there is a fear in your mind that if you do the implants again, even if you increase the number of implants or you increase the width of the implant, still there is a chance that at least the screw might break inside the implant. So these kind of cases, ये तो होना ही था, because bone loss over period of time and fibrous union is the most common complication we see in conventional implants. These all cases that I'm showing are my own cases. So I faced these kind of situations in my practice, and we still do, because we are not God. We get trained, we get expertise, but we still do mistakes. We try not to do mistakes, but sometimes it's not in your hands. So you can see the bone loss in the first case, the fibrous union in the second case, bone loss and peri-implantitis in the third case, and bone loss over a period of 1 year in the last case that I have loaded. Patient is chewing very well. Patient has no problem with this, but I try to take the X-rays whenever the patient, even if the patient comes from for another problem in their mouth. I still try to take X-rays of that side to know just how my implant is working. Biggest fears of all time is the maxillary sinus or the inferior alveolar nerve, when especially in the segmental cases. Now, doing your full mouth cases, you can avoid sinus, you can avoid inferior alveolar nerve, you can do all on four, you can do zygomatic, you can do pterygoid, but again, these are advanced procedures. You need to take more advanced trainings for these, attend more courses for these, and just one course won't suffice. You will go for another course, then another, then you'll find another mentor. You'll see that he's doing very well, he's doing good zygomatics, and you go to that mentor as well. And then you have to buy a lot of equipments, the sinus lift kits from, then you have to buy these multi-unit abutments, longer implants, a lot of these things. Now, inferior alveolar nerve, how many of us are trained here to reposition an inferior alveolar nerve? I know in full mouth cases you can avoid it. You can put 4 tilted implants in the intraforamen region. But what would you do in a segmental case where there is just the first and the second molar missing, and you cannot give a bridge, and the patient doesn't want a removable prosthesis? What would you do? Here is where the basal implants come and they make your life easy, right? Also, even if we are we are replacing a single tooth in the posterior region, can you all imagine that amount of time that you take to prepare 2 crowns and take impressions or take scans and get a bridge made for the patient? It is the exactly same time in which you can place a basal implant in that edentulous area and load the implant functionally immediately, and the patient can start chewing on the second or the third day whenever you give the cap, just like the bridge that you give. And with the same instructions that you give to the patient when you give a bridge, same instructions are given to the patient when we place basal implants, especially the smooth surface implants. Mind it, I'm saying basal implant as a bigger term, but I am referring to a smooth surface implant. I'll show you my cases. I have put rough surface implants as well, but that is a part of a big terminology that is called the basal or cortico-basal implantology. So what to do when we have to replace the 6 and the 7, the first and the second molars in the posterior region in the maxilla? There is a big sinus pneumatized, and your patient cannot afford getting a zygomatic done from a consultant visiting your clinic. And what other choices do you have? You have to give a RPD or a cantilever over the premolars and give 1/6, and you have to keep it out of bite, because even if the patient chews from that side, the 4 and 5 are going to lose the precious bone that we think that we need for the placement of conventional implants, right? So this is where the mighty smooth surface screws come to the rescue. Now see, this single block, monoblock, single piece implant has a long neck or the shaft, this area, the neck or the shaft, where there is no attachment, there is no abutment to the implant connection, there can be no micro motion in this area. You don't have to worry about the screw loosening, you don't have to worry about the screw breakage. Even if the implant breaks, God forbid, if you think that your patient will chew so hard that this implant will also break, you can very easily unscrew this implant and put another bigger size, maybe a bigger size or not. That will depend upon the case, on that situation. But it is very easy to unscrew and put another smooth surface implant in the same area without having any fear of peri-implantitis, infections, or any kind of failure again, right? You just, depending upon the situation, you can increase the number of implants if the implant has broken. You can increase the width of the implant according to the occlusal forces. So the concept of smooth surface implants is not a new concept, it's an older concept. Basically, the original studies that were done by the famous Carl E. Misch, I am sure that you all have heard his name, who are into implantology, they must have read his book. The first studies, they were conducted upon smooth surface implants, and it showed that it integrated very well over the period of time, not immediately, but ultimately. Even though we depend upon osteofixation and osteoadaptation, osseointegration also occurs over a long duration of time. We expect that our implant is going to work after we fixate it in the cortical bone, and osteoadaptation occurs over a period of time. We expect our implant to work functionally, immediately functionally. But good to know that it also integrates with the bone. You can refer to the Carl Imish book. This is not a study by me or any new mentor or a new company. It is mentioned in the Carl Imish book. The original cylindrical titanium implants were smooth surface with on which the studies were conducted. All right. So next, coming to the smooth surface implants, the basal implants. One thing I would like to mention over here, you can see the threads of this implant are a bit far away from the crestal area, which is going to be on the gingiva. Usually in the conventional implant cases, the threads start from here only, right? You just have a smooth polished collar over here, and over it you place an abutment, which is a smooth surface. So this area is free of any threads, hence a very, very, very less chance of peri-implantitis, because there is no area where the bacterial colonization might occur. So first of all, with the single piece implants, with the smooth surface implants, with the basal implants, with the cortico-basal implants, you go flapless. You don't have to raise the flap. You just need to know the the whole procedure, that how you drill. It's a different procedure. It's entirely different strategy from the conventional implants. You do not place these implants in the cancellous bone. You go deep into the cortical bone and you engage your apical threads into the cortical bone, so that we have primary functional stability, and we load these implants within 3 days. Yes, I repeat, within 3 days, you give final prosthesis over these, just like you give crown and bridges. Now see, these 3 implants are being placed to replace the 2 molars. The patient is having 4 and 5, the 2 premolars. The 2 molars are being replaced by 3 implants. Now you all must be thinking that we place 2 implants to replace 2 teeth, not more than that. Why would we need 3 implants? Have anybody, any one of you ever thought that God gave us two mesial and 2 distal roots for 6, and same for the 7? This is actually done to reduce the occlusal forces concentrated in the single area. Instead, we put 3 implants to increase the surface area through which our occlusal forces are going to go till the cortical bone. These are not going to be dissipated along the long length of this implant in the cancellous bone. These are going directly into the cortical bone. So you don't have to worry about the cancellous bone resorption, even if the patient choose on the same day when you give the bridge over it. So this case I showed you what to do in this kind of case. Yes, I did a zygomatic over here, but today if I have to do it again, I'll put one transsinus nasal implant in this area. Yes, you can go through the sinus. You don't have to worry about the sinus because it's a smooth surface. There is no attachment that is going to happen over this smooth surface area. These two are rough surface implants, but these are basal cortical implants only. These are compressive implants placed in the pterygoid. And this is the anterior nasal spine engagement, nasalis implants. And this is the welding is done over here, and over it I have given this cast bar over which I gave acrylic prosthesis for temporary purposes. Over after 3 or 4 months, I gave final PFM prosthesis over it. So peri-implantitis does not scare you anymore. I've shown you this case, the broken implants, where the patient came with the sinus with infection over this area, huge swelling on the lingual side in this area. So if anybody has ever removed osseointegrated implants, he or she might know how difficult it is to drill the bone around the implant with a trephine ring or whatever equipments do you use to remove these implants. It is very difficult and it creates a larger hole than the implant is there. If this implant is 3.75 mm or 3.5 or 3.8, the hole over here that is going to be generated is going to be more than 4 mm, because you have to reduce the bone around the implant to remove this, because this is osseo integrated. This is not fibrous union. This is not a routine union like just a tooth. The tooth is attached to the bone via PDL fibers. But this area is osseo integrated and you cannot just pull out the implant. I tried, but it just cannot happen. Also, this patient was about 70 years of age. I do not want to fracture the mandible. I don't want to lose much more bone because already the cancellous bone is gone. After I remove the implants, I'm just left with the cortical bone. So we place 3 smooth surface bicortical engagement implants. This is the first cortex through which we enter, and we land up in the second cortex. So, sorry, we gave immediate functional prosthesis over this. This is a single piece implant. We cut the abutment on the top to adjust the occlusal area, to adjust the interocclusal distance, and then we give final prosthesis over it. I do not have to worry about the gingival recession over here. This might happen, but I gave a PMMA prosthesis over it. I can change it after 3 or 6 months if there is any kind of gingival recession after few weeks or months. So this is one case where I can show you osseoadaptation in just 2 months. You can see these implants were placed immediately after extraction. So glad to tell you that this is the same case. This is the same patient. On the other side, he had broken implants, and on this side, he was afraid to get any kind of implant. He ate with a broken tooth in this area, a root canal treated fractured tooth in this area. And then I removed it. On the same day, we drilled through the mesial and the distal root area. We placed 2 smooth surface implants engaging the lingual cortex over here. It looks like it's a straight implant, but it is actually going from the buccal side towards the lingual side, trying to engage the lingual cortex. And we have placed 2 implants because just like I told you, God gave you 2 roots. There's a reason for it. We have 2 implants just to take the whole occlusal forces over here. Also, I wanted to give another implant and put a 7 over this area also, but patient had no upper 7, so nothing to worry about. So you can see this area is completely empty over here. Sorry. completely empty over here. I tried to drill over here also, but the bone was too spongy, and the cortical bone also was perforated on the lingual side. As I told you, it was a fractured tooth, and there was a good big radiolucency over here in this area. I curetaged this area, drilled through this. This is the interradicular bone. This is the distal bone, distal root area, and I drilled through the socket into the lingual cortex, drilled through the interradicular bone into the lingual cortex, and gave prosthesis immediately. Now, what we expect after extraction, we expect gingival recession, bone loss, and if we put implant over it, we try to close that and we ask the patient to come after at least 4 or 6 months. We want the bone around our implant to be healed very well, so there is no chance of implant failure. And also imagine if you put a single conventional implant over here, imagine the length of the cantilever, the mesial cantilever. Usually we put the conventional implant in the extraction site in the interradicular bone only. So when we put interradicular bone conventional implants, we give a big mesial cantilever. Let's not worry about the distal cantilever, but you can see the implant to the crown ratio is also going to be very high. We don't want a smaller implant, a big crown over it. We want longer implants to take the occlusal forces over here, because 7 is absent, or most of the occlusal forces are going to be in this 5 and the 6 area only. Also, I told you the patient has 2 broken implants on the right side, so I was little bit afraid of giving conventionals in this case. So you can see how beautifully the bone has formed in this area as well in just 2 months. This was done on 21st February, and this was X-ray was taken on 29th of the 4th month. In just 2 months time, there is good bone healing around the implant. This is what we call osteoadaptation. We might expect that there is osseointegration that has also happened in this area, but I do not depend upon osseointegration in this case. We have fixated these screws in the lingual cortex and have loaded these implants on the same day. And there is no, to my surprise, there is no gingival recession, there is no bone loss, and I gave a PFM prosthesis over it. There is no food lodgement, there is no bone loss, there is no gingival recession. Patient is very happy. Patient has came with a lot of his relatives to get these kind of implants. Nowadays patients are coming in and saying that doctor, we need these implants that you give teeth over it in 3 days only. We don't want to wait for 3 months. Sometimes patients are visiting from outside India and they are telling us that we have come only for teeth replacement and we are here for only 10 days or 15 days or 20 days or maybe a month or not more than that. So they want immediate implants, immediate cap over it, because they might not visit again in the next 2 or 3 years. Sometimes might have happened to most of you. We place an implant and the patient forgets about the implant. Remember, patient comes to you to get a teeth in the missing area. The patient does not have vitamin titanium deficiency. Patient does not want more titanium in his body. Patient just want a teeth. No matter what you give below that teeth, patient wants to chew. And if you say to the patient that you are going to give the teeth on the 3rd day only, maybe even earlier than that, imagine the amount of happiness, the amount of satisfaction, the amount of gratitude the patient is going to have. And that same patient is going to send you more cases, not just for the implants, but for the immediate functional loading, immediate crown giving, and immediate smile giving. The patient is going to be very thankful to you. There is no hassle, no 3-month waiting period time, no gingival caps, nothing to worry about the peri-implantitis, no screw loosening, no implant breaking, no this screw breakage. Okay, I want to talk about implant breakage over here. Imagine giving a single conventional implant. What I thought happened here is the number of implants were lesser. The previous dentist should have placed at least one more implant in this area. Instead, what he did, he left these 2 implants, broken implants. He might have tried to remove these 2, but he couldn't. So what he did, he gave 3, 4, 5, like canine, first premolar, second premolar abutments, and gave a big long cantilever over it. And you can see this bridge is touching over the implant. So there is a micromotion happening over this area that might have led to the periimplantitis or the swelling that was there on the time of surgery. So this is an example that basal smooth surface implants get adapted into the bone, or the bone adapts very well over the smooth surface area, and we might also expect osseointegration in a few months or years. So this is what osteofixation looks like against the osseo-integrated conventional implants. Implants done back in time, huge bone loss has happened. You can see this area has lost a lot of cancellous bone and alveolar bone. These implants are withstanding and taking the loads of the occlusal forces over these two teeth only. Here's a broken tooth. We have removed this tooth, placed the long, this basal smooth surface implant engaged in the cortex, single implant, single cap over it, and see this area, this socket area, which is here also, is starting to heal. This is, I guess, not more than 1 month follow-up. This is a 1 month follow-up only. You can see how beautifully the bone is being formed over here. This happens because we have fixated this long screw into the cortex, and we have loaded the implant on the same after 1 or 2 days, and we have asked the patient to chew on this side. Now this is a single implant. There is going to be a lot more isoelasticity over here, right? Because of the long shaft, long neck, there is going to be a little bit of movements, which we call isoelasticity. Actually, this is a property which is very beneficial in basal implants. We can attach this basal implant and the tooth together. If there was a root canal treated tooth alongside the implant, I would have given 2 caps over it. I would have done crown preparation of this tooth and given 2 caps over it. So how this isoelasticity helps is there is a little bit micromotion happening in this area, and there is bone forming around this area. This is dense cortical bone. This is not spongy cancellous bone, because according to the Wolff's law, if you Google it, if you have heard about it, if you have read about it, the Wolff law says that more the pressure that is given in that particular area. I'm actually not talking about the exact Wolff law. I am talking about how it is applied here. If the pressure is given in that particular area during healing, the bone around it forms more stronger. It is more stronger than the usual cancellous spongy bone. So this is how basal implant smooth surface works. So these are few long-term follow-ups. Single tooth, single molar given over 2 basal smooth surface implants engaged or fixated in the lingual cortex. This is called bicortical engagement. We are going through the first cortex, which is the crestal cortical bone. When you enter with the drill, it is very hard to enter. Once you enter, it is like very easy. You go inside and then again you hit the cortical bone. You put the implant through and through into the second cortex. Hence, we call it bicortical screws, BCS screws. We put 2 implants to take the occlusal load, occlusal forces of the molar, because there are 2 roots usually. God has given you 2 roots, not single root, not a wider single root. God could have given you a wider single root and gave you molar over it, but God did not do that. God had another plans. So this is according to the God's plan. This is another case. 6 and 7 replaced, first and second molar replaced with one long shaft, long smooth surface cortico-basal implant and 2 compressive implants. These are 2 compressive implants. This area is roughened to expect osseointegration, right? You can see these are at least 3 or 4 years follow-up. No, sorry, this case is particularly about 2 years follow-up. See how beautiful bone integration has occurred over this area, right? Osseo-adaptation has occurred over this area. Osseo-integration has occurred over this area. Osseo-fixation was done at the time of surgery with all of these three implants, loaded immediately, avoided cantilevers and RPDs, and gave the functional loading caps immediately over it. This was edentulous area, so nothing to worry about the gingival recession, right? So basal implants work in synergistic harmony with the conventional implants, with the teeth everywhere in your mouth. In the first case over here, I have put one conventional implant in the past. Patient wants just not the 6 replaced, but now I have convinced the patient to get a 7 replaced as well, because if I load this 6 only, this might fail in the future. So I've placed one long smooth surface implant, one short compressive rough surface implant, and I've given teeth over it. In this case, root canal treated molar, no problem in this area, good bone, good length, good width, could have given a conventional implant, but convince the patient that I can give implants on the same day, because patient came for cap over this tooth, and I asked the patient the exact time I'm going to take to cut this tooth is the exact same time I'm going to take to place these two implants, done flapless, no flaps were raised, two implants placed in the lingual cortex, engaged, fixated in the lingual cortex, and given combined two caps over this. In this case, previously treated anteriors, no posteriors present in the patient's mouth. Patient came from USA here for just 5 days. There were caps present on these anterior teeth. So I just removed those previous caps. They were porcelain was chipped off over them because there are no posteriors present. So patient used to chew in this area only. So this is very common, porcelain chipping happens. So I changed those caps and gave a combined bridge, giving two basals over here. One here, this is the canine eminence engagement. This is transsinus palatal roof engagement, palatal bone engagement. And this is a pterygoid engagement. Remember, this is not a separate pterygoid implant. This is just like a regular routine basal implant. We bent this abutment over here to achieve the right angulation to give prosthesis over it. In this case, 1, 2, 3, 4, 5, 6, and two more conventional implants were placed by me in the past. So when the patient came, these two implants were failing. There was peri-implantitis, one implant was mobile. So at that time, I started doing basals. I was already doing basals. I removed these conventional rough surface implants, put two smooth surface. Now, it's very important that I have put smooth surface in the previously infected area. Because if I put a compressive implant over here, again, I'm going to expose the rough surface to the bacterial colonization. So it is always safer to use smooth surface in these kind of cases, because I do not have to worry about peri-implantitis over here ever again. So combined with these conventional basals, canine eminence engagement, nasal floor engagement, sinus posterior wall engagement, lingual cortical engagement, straight implants in the mandible, straight implant in the mandible, lingual cortical engagement, tilted implants, and gave functional prosthesis over it immediately. So all of these patients are happy. That is the only reason I'm sharing these cases over here. So I want to tell you all that if I can do, any one of you, anybody can do. Trust me when I say this. I'm not an expert in this, but over the time I have gained knowledge. I have gained confidence that I do not have to think twice to give a basal implant to a routine patient, no matter what the age is, no matter what the medical condition is, no matter what time frame patient gives me to give him or her the teeth that he or she deserves. But if I can do it, I used to be very afraid of doing basal implants earlier, as we all know that there is a lot of negativity going on about the basal implants. The thing is that people try to place the basal implants just like they place the conventional implants, and then they expect that osseointegration is going to happen, and then they will load the implant. Or they might give a cap over it and then expect it to integrate. That is not going to happen. It is a completely different field. It is a completely different strategy. But trust me, this is just one strategy. There is just one strategy in basal implants. There is no second strategy like advanced trainings or advanced courses or advanced kits. There is just one simple kit. And most of these cases that I have shown you are done with single drill protocol. I use just one single drill to place these smooth surface basal implants, and I have not used a second drill in 90% of the cases. Now imagine you do just one good course. I'm not just saying that any course would do, but one good course on cortico-basal implantology and do just one single full mouth rehabilitation case by yourself. And by you only, because even if you call a consultant for that, you are not going to gain much out of it. If you do one good cortico-basal implantology, you get good confidence and you start the basal implantology in your own practice right away. You just have to convince one good full mouth case. And I would suggest you that you do a edentulous case for the first time. It is very easy to do the full mouth. You have the ideal strategy. I can teach you, anybody can teach you the ideal strategies to place these cortico-basal implants in edentulous cases and give a PFM prosthesis, just a simple prosthesis over it. It is very easy to do, can be done in 3 days, can be done by anybody. You can put the pterygoid, you can put nasal floor engagements, you can put transsinus engagement into the nasal floor, you can in the lower mandible you can give lingual cortex engagement, and then you can give a PFM prosthesis over it immediately and ask the patient to chew over it after you give the bridge immediately. No waiting time, no healing time, nothing to worry about peri-implantitis, nothing to worry about bone loss, nothing to worry about screw loosening, nothing to worry about changing the abutment from titanium cylinder to the permanent prosthesis, nothing to worry about the multi-unit abutments. You straight away give the implants and give a PFM prosthesis over it, and you ask the patient to chew over it. And now imagine you do just one full mouth rehabilitation case by yourself. Imagine even if you charge a very nominal fee to that patient, thinking that you are going to do the first case, you might end up doing something wrong. Trust me, if you have good confidence in you, if you have done a good course, if you have learned from a good mentor, you cannot do wrong in the first case. It is very easy to do the first case. You recover the whole course fee. You purchase a good physio out of that money. You purchase bulk implants, because there is one thing in basal implantology that you need to keep a lot of implants with you, as you cannot determine the length or the width. Mostly width can be determined beforehand, but length is never ever determined beforehand in the smooth surface implantology. You have to keep bulk implants with you. But these basal implants being economical than the conventional two-piece implants, because you don't have to invest in gingival screws, gingival healing caps, multi-unit abutments, titanium cylinders, these angulated abutments, and it is very cheap to put more implants, because these are economical. You put more implants, you get good occlusal forces balance in the patient's mouth, and you do not have to worry about failure. Then you purchase bulk implants out of that case only. You create marketing advertisement of that case. You can market your clinic, you can market yourself as a cortico-basal implantologist, and then you can convince other patients also. You take documentation, you take photographs of that case, you take testimonial, you take review of that one case and show it to other patients. Showing previously done cases by you installs a good confidence in your patient. You can very easily convince another patient to get a basal implant done and immediately loading done in that particular patient. So then it technically becomes zero investment plan to reach the superior level, where from where you are today, you just have to step up. The only thing that you need to do is a good course and convince a good full mouth rehabilitation case, and you recover all of these things from that one particular case only. You do not put money in your pocket from that case. You put the investment back into the practice. You buy implants, you buy a good physio dispenser. You do not have to work with a lower economical local physio dispenser. You can buy a good physio dispenser, good handpiece. You can invest in multiple handpiece. You can invest in a OPG machine, OPG, this scanners, anything you want to. But from that one particular case, you get at least above these five mentioned things. And this one first case is the case that gives you the confidence for future. So over the past few years, just because of basal implantology, I have been able to buy bulk implants from various companies. I've tried at least 6 to 7 companies and I have landed with a few best ones. And the biggest thing, I have bought a good damn intraoral scanner in my practice. It was only possible because I started doing basal implants. We take the money in 3 days. We don't have to divide the money over 3 months. Patients pay in 3 days. You get the bulk money in your pocket. You invest it immediately back into your practice. You can buy bigger equipments. You can buy the things that you could not afford usually in your practice. Then I have invested a lot of money in gaining knowledge. You remember, no knowledge is no knowledge is good enough if you do not apply it in your practice. Once you start applying it in your practice, then only you get the confidence for future, and then you do more courses, you meet more people, you meet more mentors, and then you make your knowledge more vast enough so that you can keep on getting more confidence. And with that good confidence, you can convince more patients. You don't have to worry. You don't have to break a sweat while talking to the patient about basal implantology. You don't have to think twice when you push the patient that the patient should get an implant instead of a crown or a bridge, right? I've made my family's life better and peaceful. I wish that all of you must step into this dental cortico-basal implantology and taste the success that I have tasted. So I am conducting this 1 hour masterclass on basal implants. The webinar that you have gone through is just a superficial knowledge. Nothing much can be covered in 1 hour. But this 1 hour masterclass, if you have attended this webinar, your next step should be a masterclass. You might not like the basal implants. You might love the basal implants. That is on you to decide. You are the better judge. You judge it by attending this masterclass. You check if this is meant for you, then only go ahead with a proper course or a mentorship program. You will get to know all about basal implantology, basics of the basal implantology, the basic concept, the basic strategies, the basic drilling protocols, the basic prosthesis. The prosthetic part will be covered by Dr. Divya. She's a prosthodontist. She's my wife, practicing with me from last 4 years now. And get a few good tips and tricks to boost your implant practice. I'll give at least 4 to 5 good tips and tricks by which you can immediately increase your practice. You'll be able to convince more and more patients on a daily basis. All right. If you have any doubts, queries, you need help with a case, you want case planning, you need to ask anything about basal implantology, you can contact me on this number. Please take a screenshot of this page. My email ID is mentioned, the website is mentioned, my Instagram handle is mentioned, and this 999 masterclass is actually going to be very helpful for you. 999 is nothing, it's just a few consultation fees. You think that you have done a charity work by doing a free consultation of 2 or 3 patients, and then you can easily get into this. Even if you get nothing out of this masterclass, it won't be a wastage of money. But I'm sure you are going to learn everything about basal implants that you need to know, and then you can decide if you want to go ahead with a proper course and a mentorship program. And for that also you can contact me. So thank you, everybody. I would like to finish the webinar here and thank all of you that you have took out time at this evening time that you are going to be spending with your families. You have spent that 1 hour over here with me. This is my wife, Dr. Divya. She is a MDS prosthodontist. She has done a BDS from Mumbai only. So that is where the beautiful processes happens in my clinic. So I just want to say one thing. that little knowledge is bliss. When I started with basal implantology, I had a very little knowledge about it. So I used to be fear-free. When I started doing the basal implants, I started reading the books about it. I read a lot of articles about it. That was when the fear came in. I thought that I had very lesser knowledge, which is half knowledge, which is usually dangerous. Then that was the point when I started studying. I studied a lot of books. I studied a lot of courses. I've met a lot of mentors in India, the leading experts in basal implantology, and I have learned from everybody of them. So what you get out of me is a conclusion of all the courses that I have attended. Every time I used to attend a course, I used to feel like that there is still a void pending in my heart, that I want to learn more. There is something missing in my practice. So I have hopefully reached that place where I think that I have concluded all my knowledge in one course, and I will try my best to teach all of you. So good, maybe not full, because knowledge is never full. Good knowledge is excellence, right? So now you can put your questions in the comment box, and we can start answering those questions. You can unmute yourself and ask your questions also. Anybody has any doubts? So there is question is how osseointegration takes place in the smooth surface of the implant. So basically, the osseointegration in implants was there was a study conducted by Carl Misch. The first study that was conducted by Carl Misch was on the smooth surface implants only. The roughening over the implants are done to increase the surface area of the implant where the bone is going to integrate and decrease the osseointegration time. But in smooth surface basal implants, we are not going to depend upon osseointegration. We are not going to expect osseointegration. Osseointegration might or might not occur. But in most of the cases, in articles, it is written, it is proved that osseointegration also occurs over a period of time. It takes longer period of time than the rough surface, but we depend upon the osteofixation and osseoadaptation. If there is osteofixation at the time of surgery, you put in functional loaded crowns over it, and then you check to see if osseoadaptation has also occur, right? Osseointegration will occur over the period of time. Osseointegration doesn't occur because of the rough surface. It occurs because of the titanium dioxide released by the titanium surface of the implants. You can read it on the Google. There are a lot of articles on Google. Next question is.
Hello, this is Dr. Sanjay Wagmare here.
Yes, sir.
What about the maxillary molar immediate molar extraction case, the two implant design? Can you please enumerate?
Sir, in the single piece implants.
No, single pill implants. Can we put two implant in the maxillary molar?
Yes, sir. It is very easy actually. When you place one implant in the palatal socket, you go inside the palatal socket, you drill through and through, you reach the nasal cortex, you reach at least the nasal cortex, you engage one implant over there, and you put one implant either in the mesial or in the distal socket.
Okay. And my second question.
I have forgot to mention one thing. To replace one single molar, at least in the posteriors, you have to place 1+1 implant. There is the number of implants that are going to be needed for replacement of molars is always going to be at least 2. You cannot give single implant, cortico-basal implant, smooth surface implant, and put a cap over it. You have to put 2 implants to balance the occlusal forces.
Okay, and which company's basal implants you are using?
Sir, I'm currently using a lot of companies. It is very easy to get in touch of a lot of companies. We get advertisements over Instagram and Facebook. But currently, I am using Bunenker. I am using this mono implants, and I am also using impact implants as well. All the cases that I've shown are done with GS implants, mono implants, Bunenker, and this impact.
Okay. Mono implant is of which company?
Mono implant, there are a lot of basal implant companies. I got to know about them through a conference that happened in Delhi last year. So I went to their conference and I bought a few implants and I started placing mono implants. I like them very much, but most of my cases are done with Bonanker and Impact only. 90% these days I'm using Bonanker only.
Impact implant.
Impact implants are also fine, but Bonanker implants have a little bit few varieties in smooth surface also. There are 2 to 3 varieties in smooth surface as well.
Okay.
So there is another question. Is single basal implant possible? Yes, Dr. Pallavi, single basal implant is possible in interior area where the occlusal forces are very less. You don't put much of occlusal load in the interiors. You give a single implant, but the main thing that you have to depend upon, you have to give an anti-rotational element over that single implant because you don't want your single implant to derotate so that it doesn't get de-screwed at all.
So how you can create that anti-rotational element on the implant?
There's a few methods, sir. First, you can bend the implant because it's a single piece implant. You have to bend it to get into the right prosthetic position. Secondly, you give a Maryland cap over it. It is very easy to make a Maryland cap. Just a small Maryland wings over the side of the cap on the palatal or the lingual side, and you give a cap over it. And other way is you can put a compressive single piece basal implant. It osseointegrates because it has rough surface also. So you will depend upon osteofixation and osteoadaptation in the initial days, and then ultimately it will integrate because it has rough surface, RBM surface.
Can you make groove on abutment part of the implant to make it
Sorry, sir, I couldn't get
anti-rotational?
you.
Can you make a groove, a small groove?
So
Or
there are already there are grooves on the abutment part. There are a lot of grooves, vertical and horizontal grooves to retain your crown.
Okay, so that will also act as a anti-rotational
No,
element.
that won't act as an anti-rotational component. But the main thing, anti-rotational component is for the apical screws so that it doesn't get unscrewed, it doesn't get de-screwed easily.
Okay.
So someone has asked, what is the prognosis of these implants? It's not a magic. I have seen a few failure cases also, but in my previous days, when the failure used to occur in conventional implants, I used to think that I have done everything pretty well. I have placed the implant subosteal. Still, there is periimplantitis. Still, the abutments are, the screws are breaking. My processes are failing. My implant is failing. But in the case of basal implantology, I have learned one thing that if the failure happens, it is because of you. It is not because of the implant. If you have placed correctly, if you have engaged the second cortex, if you have fixated the implant in the cortex, and you have done a pretty good job with the processes, it will work.
One more question from my side.
Yes,
In
sir.
basal implant, if the sandblasted surface is good or clean surface, non-sandblasted surfaces implant surface?
Sir, there are different indications for both. Usually what we do is we put compressive rough surface implants in the area where we will usually place a conventional implant, where the length is good, where the width is good, you have good cancellous bone, and you corticalize, laterally corticalize that cancellous bone and put the compressive screw into it and get the osteofixation. You do not reach the second cortex in those areas. You do not need to reach the second cortex. And the smooth surface are usually used when it's a resorbed atrophied case, where you have to avoid the lingual nerve and you can bypass the inferior alveolar nerve. And for those cases, smooth surface is preferred.
Okay.
I prefer smooth surface in almost each and every case. I have my fear is lifted now because I have done hundreds of smooth surface implants and all of them are working till day. No single smooth surface implant failure I have seen. I've seen failures in compressive. I have seen a few failures in smooth surface implants in my initial days because I used to have this fear of reaching the second cortex in the, especially in the nasal floor. I used to think, what if I drill into the nasal floor and the patient starts bleeding, and what happens if I my implant lands in the sinus? What happens if my implant lands into the nasal area? So nothing actually happens. You need to know the correct strategy, the correct drilling protocol, the correct drilling angulation, and you need to take care of your processes. It should be a balanced occlusion, bilateral balanced occlusion. You cannot give bad procedure and expect the implant to work.
Can you please enumerate more on trans-sinus implant? So we need to go through the sinus to engage the cortex or what?
Yes, sir. Actually, in that to engage the natal cortex, in which cases where sinus pneumatization has happened, you have to go through the sinus only. You put your drill into the sinus and then you engage the nasal cortex. You have to create two osteotomies.
It means we need to engage the sinus to the roof of the sinus.
You can, but it's then the implant is going to be very longer.
Okay.
The longer the implant, the more the elasticity is going to be there, because the neck or the shaft area is going to be more longer in those areas.
So
So,
in trans sinus implant cases, where to engage this thing implant?
sir, I usually do it in the full mouth cases where there is sinus pneumatization. I have shown my case. Okay, I'll show you. I don't think I have it in this laptop. So there was one case in which the failed. Zygomatic implant failed. So we tried to do another zygomatic implant, but we could not engage it in the zygomatic area because there was resorption. So when that in these kind of cases, I have put one implant in the sinus, through the sinus into the nasal cortex, and two pterygoids and one nasal floor engagement anterior to the sinus. So I've given a segmental replacement over those implants only.
Okay.
Just to replace one single molar, it is very difficult to get the nasal cortical engagement. It is you cannot do it in the first go, but the more you do, the more you learn. You have to practice on the these demo models. It is actually it is easy, but if you know the protocol, if you don't know the protocol properly, it is very difficult to find the second osteotomy created in the nasal cortex. You can enter the sinus with your implant with the smooth surface. I am focusing smooth surface because you cannot put a rough surface. You cannot land in the sinus with a rough surface implant. If you have to go through the sinus, it has to be a smooth surface implant. And it is very difficult to find the second osteotomy. But with time, with knowledge, with experience, it becomes easier. So someone has asked this: as basal implants are movable after placing, what is the success rate of placing a single basal implant? Is it a good idea of placing single basal implant? Actually, you have to take care of a few things. As I told you earlier, also, you have to take care of the anti-rotational component. It is very important because there is going to be a little bit isoelasticity in the implant. The longer the implant, the more the elasticity is going to be there. You try, if you have to put a longer basal implant, that means that there is enough length of bone and width present there. So why not give a compressive screw in that area in which the shaft or the neck is smooth? So books to be read for basal, Dr. Snehal, books to be read. There are a lot of books, one by Dr. Ide, by Dr. Scotticky, Dr. Vivek Gaur, Dr. Rohan. A lot of doctors have written a lot of books for basal implantology. Also, me and my wife, Dr. Divya, we are also coming up with a e-book for basal implantology that is going to focus only upon the clinical aspects of the basal implantology. No literature, no boring stuff, only clinical applications and the basic surgical protocols that you need to follow, and the basic prosthetic protocols that you need to follow. Will be coming up with that ebook within a few months. I'll try to inform everybody of you. Whoever wants to purchase that ebook, they can get in touch with me. So someone had asked, what if one implant fails? We need to remove the whole apparatus. What are you trying to ask, doctor? Are you talking about a full mouth case or a segmental case or a single tooth replacement? Okay, let me tell you, if one implant fails in full mouth, in segmental, even in a single tooth, you in a full mouth case, if a single implant fails, you would not get to know. The prosthesis will still work because you would have placed at least 10 implants in the maxilla and 8 implants in the mandible. If one of those implants will fail, you would not get to know, because smooth surface implants do not cause peri-implantitis. There is no peri-implant, there is not much peri-implant inflammation. A very little inflammation occurs, and that is mostly goes unnoticeable. You don't even notice it. In single implant cases, in single tooth replacement cases, you get to know there is a slight prosthetic movement. You cut the prosthesis, you remove the mobile implant, and you put a wider diameter implant over there. Or if the failure has occurred because you have not reached the cortex, then you drill till the cortex, you put an implant and you fixate the cortex, and then you load it immediately. You don't have to worry about gingival recession or a failure ever again. So if you still, anybody of you have any kind of doubts, any queries, you need help with your cases, you can share your OPGs. I have given my contact number. You can share your OPGs and you can ask for help. I'll be very happy to help you all. And I expect all of you present here in my master class. It is going to be a pivoting moment in your life. You will learn about basal implantology. You will learn about basal implantology prosthesis. The prosthetic part of basal implantology is as simple as a crown and bridge. It is very easy to learn, very easy to adapt, very easy to put it in your practice immediately after the masterclass. And literally, I'm saying this, that you will be laughing upon yourself that you have not learned about it till now. It is very easy to do. If I can do it, trust me, anybody of you can do it very easily, and you can make your life peaceful. You can get a little bit more money. More money never ever hurts anybody, right? So I expect every one of you in my masterclass. Please contact me to register for that masterclass. Thank you, Dr. Sanjay, Dr. Snehal, Dr. Pallavi. Thank you so much. So, all right. I'm going to sign off. If anybody has any doubts, please contact me at my contact number. I've given my contact number. Please ask your doubts, ask your queries, no matter how stupid it looks. Any doubt, any query comes in your mind, any kind of doubt you have about smooth surface implantology, please ask me. I'll be very happy to answer all of your questions. All right. Thank you so much. Good night.